Yes.
I'm just going to yell since I don't have a microphone, but we have a team approach that Dr. Mowat spoke about already with a lot of physicians. What's the best mechanism, or is there some way that filters that information currently?
Sorry, in terms of
just like, how do we get, you're asking for some feedback from parents, how do we get that?
How do we do that? Yeah. I've actually been talking with several other geneticists about setting up, so it kind of starts with us saying, we have questions that we want to find out from you guys. So on our end, there's some legwork we have to do up front, which is basically designing what information do we want and getting approval to go out and approach a group like yours. So I wanted to kind of plant the seed because I've been talking with other people about being able to do a natural history study, and I've gotten a lot of buy-in from other centers that are interested in participating as well, but there's a little bit of front-end work that we have to do, and then what we would do is probably reach out to the foundation and say, this is what we need from anyone who is interested in participating.
And just to add on to that, David and I were at a meeting about something completely different in Cambridge. Earlier this year, it was a presentation from Genetic Alliance, who are putting together a kind of web-based tool or website thing where people who have any condition, rare condition, can go in, log in, we select your condition, and then there'll be a whole lot of questions or natural history, lifestyle, all sorts of things that you can add in, and some free text fields as well. And also they're setting it up so that you can say and what level of release you would give to that data in terms of privacy. So you might say only the doctors at Emory or whoever can log in and get my data, or doctors Mowat-Wilson and the doctors at Emory. And so it's this whole thing where people don't have to wait to be approached by a research group. They go and say, this is the condition I'm interested in contributing to. You put it in there, and another field was approach me. You don't have the right to use any of my data, but you can approach me if you're to review any research that you're looking into. So I think they're having it very, very carefully checked in terms of the ethics of doing that and a whole lot of protective things, because you do want to have good data that you can use. So I think that kind of approach is the way that we need to go. We haven't actually talked about this together, but this is what these kind of things do, and that way we can, if it's already been done, something's really good, it's been created by somebody. I think the Genetic Alliance one looks like it's going to work. I think that's where we need to go and say what can they do for us with the model that they're currently getting checks through all their IRBs, etc.
And then if we individually have a study that one group wants to do, and it doesn't have to be us, it could be a Hirschsprung group, it could be a sleep group, it could be whoever, we can encourage them, and then this becomes a group who can then say, well, opt into that. And so, it's very powerful actually now to be able to do that. And I think the power is actually from a support group, kind of advocating for themselves, and then you're more likely to encourage us to take the extra step, because it's kind of quite difficult, isn't it? Because we've got lots of things that we could potentially do, and we have to kind of think, well, why would we do this rather than that? We're committed, and we can then help get others interested, I think.
Okay, dealing with a child with Hirschsprung's, have you ever ran into a problem where they've had to have a bowel transplant, and has it ever been successful? And do you have to live in the area where you have the transplant to have regular checkups?
Can I just clarify, you're talking about a surgical bowel transplant?
Yeah. Yes.
I'd say you're talking to the wrong people. We would probably know, you know more about that and would read about that than us, I'm afraid. If we had our Hirschsprung's colleagues here, then that would be a really, that's the sort of thing that, again, by the questions you have here, it also then says, well, actually, what we do now need is actually a Hirschsprung's expert. Okay, so this is really we would consider that what we talk about is really general overview, and then I think then maybe next meeting or whatever the interaction is, maybe targeting that, questions about that, and then how do we go about setting up answering those questions.
Just so that everybody knows what the foundation's goal is to, we have set up a medical advisory board consisting of these 3 doctors, plus Dr. Graham is going to be on it, and Dr. Butler is going to be on it, and they are going to find other doctors that will join that group, and the whole purpose is to find and create research projects that get us where we want to be. So that's kind of our goal, and that will be part of it. I mean, Hirschsprung's disease is a huge issue for all of us, and we're going to find every specialist that we can and get them together, and start working on some serious projects that will answer a lot of the questions.
Dr. Butler.
Thank you. Couple questions. I'll just speak up, okay? Is there an animal model? Has that been looked at so far, a mouse model? Because that would kind of answer some questions about the surgical transplant.
Yeah, there are a number of animal models.
Can you repeat the question?
Yeah, so Dr. Butler was asking, are there any animal models? And so, and that's how scientists and how you get basic scientists involved in this. And so there are a whole lot of kind of scientists who are interested in all aspects of Mowat-Wilson, particularly because they're really interested in this gene and what it's doing, and early on in terms of controlling pathways and development of a wide variety of the body, parts of the body. So neurologists are really interested in understanding things. The gut people are really interested in understanding this, so that they can actually get a little bit better idea about what's happening with some of the functional aspects, and how it's not just the neurons or the nerves being in the right place, it's them working in the right way. And animal models, or sort of cell models, in vitro models, are the tools that the basic scientists use. And so, we have, there are skin biopsies of cell lines that we've sent to various researchers who hopefully one day will come up with more information that will open up other doors and opportunities. So, to tell you the truth, from the point of view of the mouse models for Hirschsprung's, and whether that is such an issue in the mouse model, I can't tell you off the top of my head. But that's certainly something I'll look at.
I'm also struck by the similarity with the charge syndrome. Has that been examined? Those that we all have in our clinical practice, charge patients that have not been confirmed with the charge syndrome gene.
Yeah.
Has that been looked at? Because really, what you're talking here is so much of this overlap with charge syndrome.
So Margaret was alluding to this. I think there was a publication just coming on sort of some clinical cases where charge syndrome is. There's kids with who've been diagnosed with charge syndrome who actually ultimately turn out to have Mowat-Wilson syndrome. So that's where the co-analyte treatment comes from.
Yeah, and then those ones, it's in press in the American Journal of Medical Genetics, and those kids that had the charge-like phenotype had the same classic Mowat-Wilson syndrome mutation. It wasn't the missense mutations.
Is it deletion versus single gene defect? Structural microarray, is that helpful?
Well, 20% of people have got something that's, 10 to 20% probably have something that's detectable on microarray in terms of a deletion.
About 20%.
Yeah, and about 80% have an intragenic mutation.
Okay.
So it's in papers about whether there's a correlation with those with deletion having a broader phenotype. But in general, it's not true, although there may be some little variations with that.
Thank you.
I have a quick question about regressions. One thing I see with my daughter is she'll gain a skill, whether it's a word or walking, something like that, and then, she'll do it for 2-3 weeks, looks good, we think we're there, and then it disappears overnight, and then it's almost like she has to relearn it. Do you have any idea of the mechanisms behind these, like 2 steps forward, 1 step back sort of regressions?
I guess the answer to that is no, but it's, that's also commonly described in a lot of kids who have a significant developmental disability, that going forward, coming back, and a ratchety thing, they go plateau and drop, so no, I don't understand the mechanism. You've got your comment.
And this doesn't happen around a period of illness, because I've had a few patients where, you know, everything's going great, then they have an illness and kind of the regression and they have to rebuild up.
Honestly, she's a preschooler, she'd say half the time.
Way in the back.
So 2 things. One is if you guys, when you ask your questions, could actually speak into a microphone. That way the people who are around the world watching this can actually hear you. And if you can't do that, the doctors could just repeat the question. And 2, this is my actual question. Naomi, we've seen our geneticist one time, and when we got the diagnosis, is that the end of that relationship with the patient?
It kind of depends. I feel like, as Dr. Mowat was saying, sometimes you know, you want a really good general pediatrician or someone who's going to be taking care of all of the kind of medical stuff. It's sometimes really nice to have a geneticist be your quarterback. That's what the role that I try and play, is saying, you know, I'm the one that knows about this condition, that can advise your pediatrician, or if your pediatrician has questions, can be working and making sure that screening is being done appropriately, et cetera, et cetera. But centers do it differently, and sometimes there are certain centers where the geneticists say, my job is to make the diagnosis is made, bye-bye. That's not how I tend to function, but you will find centers like that. So I like to follow kids at least on a yearly basis.
Yeah, so I find that I can't follow up every patient I see and do that. So I choose the situations where I think I can actually make a difference. Of course, anyone can come back and see us, but we don't sort of advocate that, because in some ways I feel that allows the other people involved to not take responsibility, actually. And so I mean, our model that we would like to adopt is actually more getting our colleagues come in and give better value. On the day they come and see the geneticist, you actually see the Hirschsprung's expert and actually have a useful discussion about that. So, because through me, it's kind of, you know, it's not direct experience and it's not helpful really. And so I think that's the way we should be operating, is big centres should be getting specialists actually cooperating, and you know, you have maybe a day every now and then, and once you've persuaded your colleagues, they come along and you get it all done. But you can do it virtually. In other words, you have your Hirschsprung, you have your Hirschsprung specialist, you have your neurologist, you go and see the developmental services, you see your ped who keeps an idea of what's going on. If you want to see the geneticist as well, that's fine, and the geneticist will then would have looked up the literature and that sort of stuff. But I'm not sure most geneticists are going to actually add a huge lot of value, actually, if your paediatrician's doing their job properly. Yeah, I don't know what you think. But usually they're not, actually. So.
I think it depends on the geneticist. But, I just suddenly heard you saying, what's a quarterback? It's a little joke. I think we do tend to act a bit like a quarterback. People come to us and they've sort of fallen off the rails, so we go, okay, right, let's regroup. This is what should be happening. Let's just go through this list of things again, and these are the people you need to enlist to help you. So I guess, is that what a quarterback does?
Yes. Yes, that's what I meant by quarterback.
Here in the States, I think it's more quarterback group or 20%, maybe in Australia, but here in the States, there's a quarterback role.
Yeah, and actually I want to echo what you were saying. It would be ideal to actually have a kind of multidisciplinary clinic. That can be difficult to set up within the healthcare system within the United States, but ideally that would be the way to do it, is to come in and see multiple specialists on the same day so they can talk together, including the geneticist, who can say, I know about this condition and I want input from everybody else on, various aspects.
Middle there, the orange shirt. Yes.
De novo is not inherited by your family, correct? And it can happen environmental. Is there any research with that happening to the ZEP2? Environmental research, I guess.
Okay, so there's no specific, you're talking about de novo mutations and whether these things happen because of some exposure or something you might have had. Okay, so that's a really controversial area of genetics, the question about whether more new mutations are happening now because we live in a particular world than before. And I guess that the overall answer to that is we don't think that that's likely, that it's environmental exposures that are doing that in fact nature has always been like this, always been imperfect. And we haven't seen any particular background common to the people that we've seen with Mowat-Wilson syndrome. We haven't gone into it in detail, but I guess it's fair to say that teasing out that de novo environmental influence on new mutations in genetic material is a very, very, very difficult field. And I guess that we don't think it's likely that it's going to be due to anything that happened to you in particular. I think it's bad luck.
Just with that. But having said that, most parents, kind of don't like the fact that there's no explanation of why this has happened. But we've got no real evidence to say that there's any of these sorts of genetic conditions are more common now than they were previously. And if you look at examples of conditions which we described many centuries ago, they were around then, they're around now. We haven't seen any clear-cut change in prevalence or incidence of these disorders. So if there's an effect, it's a small effect. But it's like anything, you have to keep an open mind because, we can't be fixed in our way of thinking because, then we won't be able to kind of change things in the future maybe. Do you have a...
There's just a lot of people in the area with this or similar in our state. It could be coincidental. I don't believe that though, but I went 14 years.
Yeah, of course. And so I was saying there was sort of 5 families or something in the area in Kansas, So I mean, look, one of the most common question I get asked in clinic for whatever the condition is this something to do with the environment? Because there's been a sort of a cluster of cases, and whenever the model of clusters that's been most investigated is cancer. And there hasn't really been a lot of work done on genetic conditions, and the reason for that is, all the data suggests those clusters where they exist are probably just chance. And so, to get back to what I said before, I can't rule it completely out. We've got no strong evidence to suggest it's anything other than just that natural creation of new mutations, because we all have new mutations. Actually, if now we've got the genome data, sequencing that we can now do, we all have new mutations that we didn't inherit from our parents in our genome. Only 2% of our genome actually codes for really, really important genes. And of all those 20,000 genes, only a proportion with an acquired mutation will lead to a human disease. So there's a process going on in all of us all the time. The ones who have a new genetic disease are the ones who are just unlucky enough that genetic change has happened in a key place, and then we're seeing the end result. So that's the background, and we understand the biology of that. So that's why we don't think that the environment's actually a huge issue. Now, having said that, the reason why we develop new mutations is related to our environment, UV light and all that sort of thing. And so, there is an element of the environment being a contributor in that process. But we're not seeing a massive explosion in genetic diseases, because it should occur across the board if that was the case. So, the guy in the dark. Yes.
all of these kids have their baseline medical conditions, but is there anything from a genetic standpoint that impacts lifespan, or we don't have enough data yet?
Yeah, no, look, I would go with the crystal ball really and say my crystal ball doesn't work any better than anyone else's crystal ball. I mean, of course, longevity and aging, and there's so much research on this sort of area, you know, it may be that there may be a sort of a profile or a suite of tests that we can do that this person is actually more at risk in their lifetime of these conditions. And so you may well be able to kind of target management, but we can't even do that in the general population, let alone, you know, individuals in this situation.
But I guess, I'm not sure if you're asking the question of whether we know that there's decreased lifespan. Is that the question you're asking?
Yeah. Just from a genetic standpoint, this missing gene sequence, does that impact lifespan, or is it not relevant?
We would have to collect the data on a particular condition to be able to answer that, and you'd have to get a lot of data collected. And as other people have said, we don't have a lot of data about adult people, because they haven't been diagnosed up until now. So you need a lot of data to make any worthwhile statistics. What we've observed is this doesn't appear to be a condition where there are people who die with this condition in early childhood, mainly due to their cardiac problem, occasionally due to other problems. But it seems that people who get through those health problems over the period of time that we know most people, say sort of the 1-year-olds to the 25-year-olds, once they're here, they seem to be kind of here. So we don't know whether there's early aging or other life things that happen, like in Down syndrome. We have the data that says that people have premature onset of this and that now, that we just don't have the data for this condition. But people seem to be pretty well and pretty robust, despite really quite strong medical problems sometimes. I've seen it. It's not an anecdotal view of it.
I would agree with that. I think that when you look at large populations of individuals that have significant intellectual disability just in general, there does tend to be a slightly decreased lifespan, probably related to mobility and things like that, but not significant. So, but we don't know the data in this particular condition.
The question is, we talked about a lot of characteristics that are acknowledged and seen at youth, and it seems like as they get a little bit older, into adolescence and older, some of those characteristics, seizures, seem to calm down. Are there new items that show up as they get a little bit older? And then also, our daughter has significant skin discoloration visible under UV light. Is that common?
I'll do the skin discoloration one. Okay, that's really interesting. I'm interested in that because a couple of our patients that we've seen have skin discoloration that's visible in general light. So one of my patients and one of our patients has this interesting skin discoloration. There's a little girl that lives in the US who has some skin discoloration, including a little white patch on the front of her hair. And I tried to get together some information about that a few years ago, but it didn't go anywhere. There's a patient in Italy who does the same. So I think there is a pigment difference in some people, and that's really interesting. The UV thing is really interesting. Maybe we should look at some people under the UV light. Pigment cells are melanocytes. There's a connection between the way those pigment cells work and the way that the nerve cells work. There may be, so there's some sort of connection about the way those cells move. So I think the pigment is part of it, and why it's in some people and other people, I don't know. But yeah, we've seen this progressive depigmentation in one patient that we know. Lady in the green, I think.
I had an idea for you guys. Is your child under a lot of like CT scans or x-rays that could cause them to glow under UV lights?
You can see sorry.
Mike.
You can see the pigmentation and discoloration just with the naked eye as
Yes.
well.
Okay.
I used to rub her skin thinking, oh my goodness, this little dirt spot is not going away.
Mm-hmm.
We went to the dermatologist, and then when she was put under the light, I
much more
realized that
obvious.
it's not just
Yeah.
that localized, it's like all over her body, and they're pretty significant.
An
And
interesting
there's white spots as much as dark spots that
Sure.
are visible to the naked eye, but I'm not
Straight
sure.
lines, there's all kinds of.
Yeah,
That's really interesting.
I'm not sure if it would be due to exposure to X-rays or whatever. She
So-
had
Okay, so the cell origin of the problem is in a cell called the neural crest cell, and that's a collection of cells that forms very early on in development, kind of along the side of the neural plate that's going to go on and form the brain and the spinal cord. And those cells in that neural crest are going to be in just about every part of the body, including the bowel, the brain, the skin, the palate of the face. And so ZEB2 is critical for the normal function of those neural crest cells. So not everybody develops everything, so clearly even if you've got a mutation which messes up one copy of the gene, that isn't enough to cause the same problem in everybody. And presumably there are other factors that will affect that, and that'll either be other acquired mutations as the cells develop, or other genetic factors that might predict it. But it's the neural crest that's the problem. Fortunately, it's not a health issue, the pigment side of things. I don't think that places anyone at higher risk of anything, other than maybe sun damage if you're a bit depigmented. Just be careful with sunscreen and things. So I don't think it leads to some tumours or anything like that. So it's more an observation.
And also, we have problems with the platelet function, where it's easy bruising to, like a minimal touch can cause a huge bruising that it will show up to a bigger injury that it would actually causes bone fractures and that kind of stuff. Is it part also of the syndrome, or is there something else that could be going on?
So again, what you've heard really today is kind of what we know and what we kind of feel confident about. But we've already heard new stuff consist from different families, which make us think, is this just a one-off association, or is it something that's affecting more than one individual, in which case it may be definitely part of the condition, and all I can say is, that needs to be appropriately managed and looked after. It may help us with, maybe reflect on the biology perhaps, and then better care for people in the future if it's got some health implications. So I think this is where the learning comes from, and we've mentioned, there are other things related to the spleen that several families have mentioned, or perhaps some immune function, which really is not actually on our radar in any way that's significant at the moment, but is really important because this is the stuff that's going on in your lives. And I think if that information was actually documented, then you're more likely to get traction and get it better looked after. So I think that's the value of getting this information.
We talked about how they're really happy all the time, but have you all ever done any research on like real behaviors like pinching and scratching and biting and stuff like that? And what have y'all found?
What we've done is just document it rather than, and that's what Liz Evans did, was really kind of how common are these things and compared with an equivalent control group with similar perhaps level of functioning. Clearly they're not going to be completely the same. And a lot of those things are happening now. What you really want to know is what's, I suppose, is an intervention if you've got something. That's, and again, I think a behavioural psychologist is a very invaluable person. And if you can find someone in your local area who can give you strategies of how you deal with a behaviour, if that's the behaviour you want to change, you can't change everything. There's lots of things happening. The approach would be, well, let's actually concentrate on one thing, and then you invest time on that. But that's the realm of a behavioural psychologist to sort of help you with strategies of how to do that. And again, that's outside my expertise.
Okay, and her neurologist at the University of Louisville said that Mowat-Wilson is like under an umbrella of cerebral palsy. Is that true?
Oh, God.
We need another conference.